And then they go to the doctor. Then the doctor does a lack of physical exam because it's not thorough at all, gets the imaging and goes, oh, yeah, you have these findings on imaging that we didn't know about before because you never had imaging before. You have these findings on imaging, that must be what's causing your pain. Hey everybody, so it has been a little while since I have talked about low back pain, and someone in my comments on Instagram today actually had asked if I could do another video on low back pain. And so I thought this would actually be a really great opportunity just to kind of talk through just some different concepts that I think about, one as a physician, but two also from experience with having intermittent chronic back pain over the last 6 years or so. And so I wanted to take this opportunity to talk about that type of stuff. And so first, I want to give you a little backstory on what happened with my back pain, because that might help some of you in the process of figuring out your back pain, on why you have pain, why you haven't been healing, and maybe some different ideas and strategies to heal. So I was in a car accident in 2012 where road conditions up in Canada weren't that great, and I ended up rear-ending somebody on the highway. And I walked away from that accident fine. I was a little stiff the next day, kind of all along the erector spinae from my neck all the way down to my tailbone. But I was okay in the sense that I didn't actually injure my back at that point. But probably about 2 weeks later, I was in the gym and I was squatting. And at this time, I was a competitive track and field athlete and was squatting pretty heavy and felt a little kind of tweak in my back. Now, I'd never really tweaked my back before, so this was the first time that had happened. And so I was working with the athletic trainer in the chiro and kind of got that resolved over a few days, and it went away. However, about 2 weeks after that, I was doing some repeat 800s on an indoor track, and on my last rep that we were doing was running, and I felt my kind of lower abdominal core and my pelvis just kind of like give out, and then I felt this kind of rotation in my pelvis, and I felt something just kind of give, and it was insanely painful, really, really hard to walk, had to brace my core a lot to be able to do that. And then the next morning I woke up in pretty excruciating low back pain that radiated down the leg. And I had the classic symptoms of a herniated disc, where any form of coughing, sneezing, bowel movements, all that type of stuff was so insanely painful that it was really hard to bear. And at that time, a cough or a sneeze would actually take me down to my knees. That's how painful it was. And so, from there, I ended up getting some treatment and kind of just managed the pain. You know, I was stuck in that place where my pain really wasn't getting better, but the therapies that I was doing, which was a combination of physical therapy, some massage, some acupuncture, some chiropractic, and then ended up seeing a European-trained osteopath who does a lot of visceral manipulations. All of that kind of kept me status quo. I was in daily pain, but doing all that stuff kind of kept me around like a 3 to 4 out of 10 with the occasional spikes up to about a 5 or a 6 maybe. So again, it wasn't like completely debilitating, but it was present every single day. And this lasted for, I think probably about 2 years. So during that time, I moved out here to Arizona, started naturopathic medical school. And because of my interest in sports medicine, I ended up going to a conference out in Florida, which was the American Academy of Orthopedic Medicine, or AAOM conference. And at that conference, I was evaluated by an extremely knowledgeable doc out in Texas. His name is Brad Fullerton with Prolo Austin. Did an evaluation on me under ultrasound, and then actually treated me at that conference several days later with PRP. And that was the first time, and at that point, probably about 2.5 years, that I had actual significant pain reduction to the point where 3 months later, I was just about pain-free and was back in the gym, at least doing some form of weight training, because I couldn't up till that point. And then to make a long story short, over the next few years, I was hit on the highway. I was rear-ended at a stoplight from a kid playing Pokemon Go during the Pokemon Go craze. And so I've cycled in and out of low back pain. And then it was 2.5 years ago now that I had my first bone marrow concentrate stem cell procedure while I was in, actually just before residency. It was in residency, I think. Anyways. And ever since then, I have, for the most part, been 95% pain-free. Probably about 9 months ago now, I had a little episode at the gym where I kind of tweaked my back, but I kind of worked through that in about a week's time. And this is actually where I want to go with this conversation. But worked through that in about a week's time, and ever since then, it has been pretty good overall. So some of the big things that I want to talk about for the low back. So a lot of the times where I think kind of the insurance model has kind of gone off base a little bit in terms of diagnosing and treating low back pain is this huge reliance on imaging. So generally what happens is the flow is that a patient goes to the doctor, they say, Doc, I have low back pain. The doctor goes, okay, they might do a few physical exams just to kind of rule out like the big red flag stuff, like you don't have cancer, it's not an infected disc, stuff like that. They kind of do some mediocre tests because, again, in the insurance model, docs don't really have a lot of time to spend with patients. And to be honest, my physical exam and docs in my space, our physical exams are longer than the entire appointment sometimes that people might have in the insurance model. And so anyway, so patient comes in, says, Doc, I have pain. Doc says, okay, let's get imaging. Imaging comes back and that imaging shows degenerative disc disease, or it shows some bulges, or it shows a herniation. And then the doc goes, oh, I found out where your pain's coming from. Here it is on these images. Now, that is a huge fallacy right there. And the reason for that is because there are many people right now walking around with degenerative disc disease, a bulge, and a herniation that are absolutely 100% pain-free. Yes, you can have degenerative disc disease, a bulging disc, or a herniated disc, and you could be 100% pain-free. So one theoretical scenario that I think happens a lot is patients have these findings already on an MRI, and that is supported by research that shows if you take 100 people who do not have low back pain, who are 100% pain-free, if you take an MRI, you're going to find degenerative disc disease or a bulge in 50% of those people, so in 50 patients, okay? So somebody might have these changes already on an MRI. And then something happens where another structure in their back gets injured, whether it's, and the big ones I see are the facet joints, the sacroiliac joint, the superior and middle cluneal nerves. Those are probably the biggest ones. And then they go to the doctor. Then the doctor does a lack of physical exam because it's not thorough at all, gets the imaging and goes, oh, yeah, you have these findings on imaging that we didn't know about before because you never had imaging before. You have these findings on imaging, that must be what's causing your pain. You have severe degenerative disc disease. Let's get you scheduled with a spine surgeon. And from there, then it might become whether it's going to see pain management and you're getting medications, or you're getting steroid epidurals or injections, or you're being referred for surgery based primarily off of image findings and not as much a proper physical exam. And so going back to my example of when I tweaked my back about 9 months ago, if I had tweaked my back there and I would have gone to a doc, and if I wasn't who I am right now in this space, and I had gotten an MRI, it likely would have shown that I have a bulge and or an old herniation and degenerative disc disease because I already know I had that stuff, okay? But if I didn't know I had it and I was just in the general public and I had that imaging done, I get, as a physician on the outside, I get how some people might go, oh yeah, that must be causing my pain because this imaging showed something and I wasn't in pain before, so it must not have been there, okay? So when I tweaked my low back, what actually happened was a superior and a middle cluneal nerve neuralgia. Basically, during a deadlift that I was doing, I irritated and mildly injured the superior and the middle cluneal nerves. Those nerves supply innervation over the buttock and kind of the sacrum area, okay? Kind of in the area where your SI joint is. I'm gonna stand up here, I think you can see, kind of in this area here is where those nerves are gonna give innervation, which is where a lot of people feel their low back pain. And so I ended up giving it a few days, and then I did 2 perineural treatments. Well, my wife did 2 perineural treatments on me, and I was 100% better, and I was back in the gym. And since then, you know, I have been working on establishing better movement patterns so that I'm not at a disadvantaged position to injure them again. But it, you know, I even had, it was funny, there was someone on Instagram who called me out and basically, I don't want to say he called me a fake, but basically told me that I was incorrect about my diagnosis on myself and that it was a disc issue and that the cluneal nerves rarely ever cause acute pain. And I will fully disagree with that. I see it all the time in my clinic. Patients come in excruciating 8 out of 10, 9 out of 10 pain, but they don't have the classic symptoms of a herniation. They don't have pain that radiates down the leg. They don't have increased pain with a bowel movement, a cough or a sneeze, things like that. And we do a perineural treatment, which is 5% dextrose subcutaneously, and pain goes from, you know, an 8, 9 out of 10 down to like a 2, 3 out of 10 that day, and then that continues to persist. And then after a few treatments over a few week period, they're almost 100% or 100% pain-free. And so yes, the cluneal nerves can cause and do cause acute low back pain, and I think it happens a lot more than a lot of the world even realizes. So that's kind of the framework that I wanted to give. Now, if you're sitting here and you're like, okay, doc, talk to me about my back pain. Here's what I'm gonna say to you guys. If you have pain that gets worse when you lay on your stomach, meaning like, so when you're in bed, you cannot sleep on your stomach because of low back pain, it's a high likelihood that your pain is most likely coming from your facet joints or your sacroiliac joints. Now, it might be from the posterior cutaneous branches of the dorsal rami, which are the cutaneous branches that come off of these, the dorsal rami, which come off of the nerve roots at each of the levels. That's a lower possibility, but still possible. But most of the time, if you're laying on your stomach and that causes you a great deal of pain, it is likely your facet joints or your sacroiliac joint. If you have trouble getting up from a seated position, meaning like when you're on the toilet or you're sitting down for a long period of time, and when you go to get up, if that causes you low back pain, there's a high likelihood that that is actually sacroiliitis or inflammation and some mild arthritis of the sacroiliac joints, whether it's just one side or both sides. And then the other layer to that, the next thing I would look at if it wasn't sacroiliac joints would be the superior and middle cluneal nerves. Again, as when you go to stand up, what happens is the posterior aspect of the pelvis compresses, it opens up a bit, which gaps the sacroiliac joint. And when that happens, that can cause pain for your sacroiliac joint, but also the muscles of your lower back, so your erector spinae muscles and your glutes have to contract when you stand up to create tension. And if the nerves that are going through those muscles or through those fascial planes, when you clamp down on them, that could irritate them and that could cause you pain. And so again, standing from a seated position could be sacroiliitis, or it could be the superior middle cluneal nerves. If you have pain when you look over your shoulder, okay, so let's say you're driving and you go to look over your shoulder to check your blind spot or check this way, and you have low back pain that's around your sacrum, then that could be sacroiliitis as well. But again, it could always still be the nerves. And then if it's a bit higher up, meaning it's kind of above your iliac crest, which is the pelvic bone there, then that could actually be your facet joints. And then the last one is if you have pain that gets worse when you bend forward. Now, this one can be a little bit tricky because, when you bend forward, you actually place, what happens is you have your discs here, okay? This here is the posterior side, this here is the anterior side, okay? When you bend forward, what happens is you compress the front side of the intervertebral discs, and what that does is it kind of pushes and smushes what's called the nucleus pulposus inside the disc, it actually pushes it backwards a little bit. Okay, and so if you have a tear in the annulus, which is the ring around the intervertebral disc, or you have a frank herniation or something like that, what happens when you do this is it's kind of like a jelly donut, right? You push on this end and it could squirt out this end. So the herniation, the nucleus pulposus, could come out the posterior side. And so when you flex forward, and if you have low back pain, that could possibly be a disc issue. Now, if you do that and you have pain that goes down into the leg, right, whether it goes to the back of the leg, the side of the leg, into the foot, then that could be some a disc bulge or herniation pressing on the nerve roots, okay? But if you kind of have more diffuse low back pain, especially like right around your sacrum and your SI joints when you bend forward, it's actually most likely your cluneal nerves that are causing that. And the reason I say that is because when you go into that flexion position, what happens is you're taking all of these muscles that kind of have, here, let me try this. You've got the nerve that's piercing through these muscles, right? And what happens is you've got these fascial layers in the muscle, and when you go and you stretch the low back, right? Because going into a forward flexion position is going to stretch the muscles of the low back. When you stretch, what can happen is you can actually pull tension on those nerves. And if those nerves are inflamed and irritated and they have neurogenic inflammation, then that stretching can get to a point where it starts to fire off pain signals. And so you can then have pain because of that. Now, if you arch your back up like this and have pain as well, and it's not your facet joints, it could still be nerves. So the nerves can kind of go both ways in that sense, meaning when you stretch the nerve and when you compress the nerves, you can have pain on both of those. So we already explained the stretching, but then the compression part is if you have this going through a muscle, or we'll do it like this, you have this going through a muscle, and then you squeeze the nerve, right? So you're here, and then you contract the muscle and you squeeze, you're now squeezing on the nerve, and that compression on the nerve can again send off pain signals. And so the nerves can always be in play, and a lot of the times, I'd probably say 90% of the time, if I have a known, it's a sacroiliac joint, or it's a facet joint, or there's an annular tear, anything like that, there's a structural issue that we're more commonly talking about. If we have that, I'd say 90% of the time there's also overlying neurogenic inflammation that is contributing to the pain. And so a lot of the times I'm actually treating both of these things together. Now, if you have had back surgery, the chances of you having neurogenic inflammation skyrocket, because when they cut through those muscles, they're changing how the fascia moves, they're changing how muscles can contract, they are changing the tissue integrity there, which is important because nerves can get trapped in scar tissue. If things don't slide properly, nerves can get trapped in the fascia or the muscles more, and so there's always a higher chance of neurogenic inflammation in anywhere where there's been surgery. So that's kind of where I wanted to go with this video, is just kind of talk about, some different ideas on why you might be having back pain. Now, on the treatment side of the equation, there's many different ways that you can treat low back pain and get resolution. What I personally specialize in and what I enjoy doing and what I find really effective is the regenerative injection therapies. That's things like prolotherapy, PRP, autologous stem cell therapy, the perineural injections, nerve hydrodissection. All that stuff is really beneficial in cases like this, because we are attempting to get at the root cause of the actual tissue dysfunction, which is usually some form of neurogenic inflammation, tissue inflammation, and or tissue degeneration. And so based on what we have going on, we can choose the appropriate therapy to help patients get out of pain long-term, the way that I've been helped to get out of pain long-term. So I hope this helps give some clarity for all of you out there who are suffering from low back pain. And if you have any questions, please hop in the comments and let's try to discuss it. See you later.